let's, for the next half an hour or so, look at non-invasive tests for the assessment of liver damage. I suppose if you look at every treatment algorithm that talks about managing hepatitis B or hepatitis C, within every algorithm there is somewhere where you have to consider a biopsy or some form of assessment of liver damage. And I think this is really important because you can't get away without assessing liver damage for managing chronic viral hepatitis. But we also know that there are numerous causes of liver damage with various viruses, immune restitution, alcohol, drugs that we use for hepatitis. But all of this boils down to one thing, that the end product of liver damage is fibrosis and cirrhosis. And so in order to understand how to assess liver damage, we really need to understand a little bit about the physiology of hepatic fibrosis. So you all know that no matter what causes the liver cell injury or the chronic nuclear inflammatory response, the end result is that you get these growth factors that are released that activate hepatic stellate cells. And this activation of hepatic stellate cells then leads to laying down of collagen and progressive fibrosis. Now, we're all aware that, hepatitis C and hepatitis B cause liver injury and a chronic necroinflammatory response. But what you also need to be aware is that HIV itself can directly stimulate hepatic stellate cells to give you liver fibrosis. And so we're going to see, as years progress, not only an effect of hepatitis co-infections, but also an effect of HIV that we'll need to think about. Fibrosis in the liver is very much like clots in blood, in that this is a dynamic process of collagen being laid down and collagen being broken, and it's not a one-way street, it's a two-way process. And so, you get on the one hand fibrogenesis, on the other hand fibrinolysis, and this is clearly important because this then makes us realize that liver damage is not irreversible, but can be reversible if managed correctly. What it also helps us do is that we know that there are a number of tissue inhibitors that spill out into blood, and we can exploit this in terms of how to quantify fibrosis in the liver. So why do we need to stage and grade liver disease? I think the first thing we need to do is define what grading and staging of liver disease is. So when hepatologists use the term grade, they talk about the degree of inflammation and hepatocellular injury, which is then going to lead on to fibrosis. And the stage of liver disease then is the level of fibrotic liver damage that ranges from fibrosis to cirrhosis. The other thing to say is that, we've talked about this for the last couple of days. People have talked about ALTs and liver enzymes as a marker of liver inflammation. What ALTs do very poorly is to discriminate different stages of fibrosis. And so, this is a very old slide, but it's one that's brought up very often. This is looking at liver histology in patients with elevated and normal ALTs with hepatitis C. And as you can see, even in the presence of a normal ALT, you could have significant fibrosis within the liver. And so, liver enzymes are not great markers of underlying liver fibrosis. We've seen this before. We know that in the context of HIV, hepatitis C co-infection, progression to end-stage liver disease is very rapid, and hence there's a constant need to be assessing people frequently in order to intervene at the right time in terms of hep C HIV co-infection. So, just to kind of try and summarize that, we need to look at reasons why we need to stage disease in co-infected patients. We really need to do that to make patient management decisions, to prognosticate. We know that liver disease progression is not linear and that can be accelerated in some patients, so we need to assess progressive changes. We need to look for alternate pathologies because, remember, there's not a single cause of liver damage, but often a number of different things can come together to cause liver damage. And clearly the most important thing of all is we need to identify patients with cirrhosis early so that we can target these for HCC screening, assess for complications of portal hypertension, and institute strategies to prevent decompensation, and perhaps, as we'll learn, think about assessment for liver transplantation. So how can we evaluate hepatic fibrosis? What are the tools that are available to us? Well, clearly up until the last few years, liver biopsy has been seen as a gold standard, and liver biopsy still is a good way of assessing liver damage. We can now do blood tests. We talked about components of the extracellular matrix and non-extracellular matrix that spill out into blood, so we can put these together in beautiful indices that will tell us whether somebody's got significant liver damage or not. We can do transient elastography, and then perhaps we'll look at stuff that's happening beyond transient elastography. Okay, so let's go back to the liver biopsy. Is it really the gold standard? So let's talk a little bit about the liver biopsy. In order to understand the staging and grading, one needs to understand a little bit about the histology of the liver. So you are all aware, going back to your good old medical school days, that the liver is organized into these very nice hexagonal lobules, or acini as they're called, with in the center the central vein, and then in the corner the portal triad, and then in between you get the wonderful sinusoids and the sinusoidal cells that sit in front of the hepatocytes. So this is the sort of basic lobule, or the acini of the liver. And in terms of inflammatory grading, one starts, and there are a number of different grading systems, but in essence you can look at the amount of interface hepatitis that progresses between different grades, and then start to get bridging necrosis. All of this will then translate into fibrosis, and this is one of the kind of easiest fibrosis stages that we have, which is the Metavir score, where 0 is no fibrosis. Then you've got portal fibrosis. It then works out from the portal tracts, and you start to get portal bridging, and then you start to get portal central bridging, and then eventually it all ends up in nodule formation or cirrhosis. There are a number of different staging systems. So there's Ishak, there's Metavir, there's Nodel, but all of these basically describe what's happening within the context of a liver biopsy in terms of collagen deposition, initially within the portal tracts, and then portal bridging, and in the end cirrhosis. So having done all of these staging systems, what we need you to appreciate is that liver staging is a descriptive term and not a quantitative term. And people often use liver staging as a quantitative measure. And so, you've seen papers where people describe a regression in Metavir scores by 0.2 or 0.5. And you cannot quantitate that, because what you're doing is just describing what you see in front of you. So if you take, for example, this very nice approach to liver disease staging, which is collagen quantitation. This is some of the work that has been done at the Royal Free by Professor Dillon's group. Then if you look at the Ishak stage and compare that to fibrosis measurement, i.e. quantitation of the collagen, then you can see that the relationship is not a straight line. If example, you went from Ishak stage 1 to stage 3, you actually increase your fibrosis percentage from 3% up to 6.5%. So you're actually doubling the amount of fibrosis that you're seeing if you quantitate the fibrosis. So the take-home message here is that staging that one gets from the histopathologist as a Metavir score, or a Nodel score, or an Ishak score is not a quantitative measure. It's a descriptive term, and one should not use it as a quantitative term. And in fact, we may be better off doing things like collagen proportionate areas and actually quantitating the amount of fibrosis that one sees. There are clearly issues in terms of liver biopsies, in terms of where you take your liver biopsy and how much you can quantitate. And so this is, again, a slide that, is very often used in talks like this. So if you take these two areas of a liver biopsy, and if you quantitate the amount of fibrosis within two areas that are separated by micrometers, so to speak, then you get completely two different readings. So this is, again, a suggestion that liver biopsies are very, very, very subjective in terms of where you put your needle in. The length of a liver biopsy is also very important. This is, again, another slide that's very often brought up in talks like this. This is a post-mortem study from ages ago, which looked at different biopsy lengths and then its sensitivity in terms of different METAVIR scores. And as you can see, perhaps your ideal liver biopsy length is about 25 millimeters. That's 2.5 centimeters of liver, which is really difficult to get, even in best hands. But the important thing is, does histology predict outcomes for patients? And we've known this for many years, that if you look at baseline histology, you will actually predict outcomes in terms of mortality, hepatocellular carcinomas, and complications of end-stage liver disease. So liver biopsies are particularly useful, and even the METAVIR scores, even though they're not quantitative, they will predict what's going to happen to a patient. So this is some nice data from Mark Sulkowski's group, looking at baseline histology, METAVIR stage, and then risk of end-stage liver disease, hepatocellular carcinoma, or death. So liver biopsies are not all difficult and useless, because they will actually predict what happens to people. There are problems and limitations of a liver biopsy, though. For most patients, this is not an acceptable procedure. It is costly. It costs about £1,000 per biopsy in the UK. There is morbidity associated with this. It's low, but it's significant. And then clearly there are reliability issues, both in terms of length of a biopsy, inter and intra-observer variability, and most importantly, when you do a liver biopsy, one assumes that what you've got in front of you is what's happening throughout the liver, and it may not actually be true, because you assume that there's a uniform disease process, and we all know that liver damage is not a uniform disease process. So what about the blood panels? What can we do, and how can we make things better by not doing liver biopsies? So these are the so-called serum markers, and what they do is they actually use extracellular matrix components and regulatory proteins together with a few indirect markers of liver damage. And so these are some of the components of blood panels, and not all of these are used in every blood panel. So this is an example of a number of panels that are available to us and what tests are within these panels. As you can see, many of these tests are routine laboratory tests. Many of these are not available in routine laboratories. And so people try and put all of these together to try and come up with complex equations that then help you predict how much fibrosis somebody has got. Do they help? Do they work in co-infected patients? Clearly, a number have been evaluated in HIV settings. So this is Fibrotest for HIV Hep C co-infected patients. And as you can see, they're really good at discriminating people with no fibrosis from cirrhosis. But in between all of that, there's a big overlap. Yes, and so what you get here in this group of patients is you could probably have avoided liver biopsies in more than half of these patients, because your Fibrotest actually works. But what it doesn't do is tell you discriminate between, say, 2 and 3 or 1 and 2. So currently available biochemical markers and scoring systems that have been evaluated in HIV positive patients is APRI and FIB4, which are very common because they use markers that are commonly and routinely available in labs, and there are all of these others that are a bit more complex. You need to be aware that many of these markers use bilirubin. So if you've got patients on boosted atazanavir, for example, you may get false readings, and there are some tests that now correct for the hyperbilirubinemia that you can get with atazanavir, for example. Okay, so what about transient elastography? Again, we've seen this picture before. This is the old Fibroscanner with me trying to not hurt one of our nurses who's in that picture below. So the concept of elastography is very, very simple. What you do is you generate a shear wave within the liver, and then you measure the speed with which it travels through a known portion of the liver, so a predefined portion of liver. And the stiffer the liver, the faster the elastic wave travels through the liver. So, for example, if you've got a nice wobbly jelly, then it takes a longer time for the shear wave to move through the wobbly jelly. But if you've got a stiff bit of wood, then it moves through it very quickly. It's a very simple concept, and I think the concept was first developed by the French, like with everything else, to see if the soft cheese was ready to eat. Yeah, and it's true, isn't it? It's a very simple concept, but very effective concept. Okay, so the big advantage of the Fibroscanner in terms of assessment for the liver is that, when we talked about liver biopsies, the needle is very small, and so the liver biopsy needle assesses 1 in 50,000 bit of the liver. The volume of the Fibroscanner is much bigger, and in fact, it assesses a much bigger portion of the liver than a liver biopsy can. And so clearly, we're starting to see advantages of Fibroscans over liver biopsies already, just in terms of how much of the liver this assesses. Is it useful in practice? Clearly, we've seen data that it works for hepatitis C in the context of HIV. Again, very similar data to what we've seen for Fibrotest, for example, where it's very good at discriminating people with no fibrosis from people with cirrhosis, but what it doesn't do very well is discriminate people in between. How does it work in practice? Certainly for hepatitis C, the cutoffs have been very well defined. So a cutoff of 7.65 suggests that liver has got fibrosis greater than F2 on the Metavir score. A cutoff of 14.5 is very discriminatory for picking up people with cirrhosis. Cutoffs vary by disease, and I'll show you some data in the next slide. The same cutoff, say, for example, 7.8, would define cirrhosis in B rather than F2 fibrosis in C. And so one needs to be wary what disease that you're looking at in terms of the cutoffs that you use. For some reason, men tend to have higher readings than women. First reading is often bigger than the subsequent readings. Age seems to have an effect in terms of your transient elastography, and clearly if you've got a high body mass index, then it's not possible to get a reading from the Fibroscan, although there are now probes that are used for people with high body mass indexes. There is observer experience and a learning curve, and it's thought that you need to do at least 500 examinations before you become proficient at using a Fibroscanner. I don't think you need it to be that high, to be honest. People with high BMIs, subcutaneous fat, and ascites, clearly they won't be able to get readings from. And then there are certain things that will give you falsely high readings on a Fibroscan, particularly inflammation of the liver. So in the context of acute hepatitis, you'd get a higher readings from a Fibroscan. Right heart failure will give you higher readings because of congestion within the liver. And then there is some data to suggest that if you've had a big, heavy meal, so you've got your bile flowing through the liver, that could also give you a high reading. And so, I often say to people that come to clinics with us in the afternoon on a Tuesday, if you don't want a high reading, don't have a big, fatty lunch so that we can assess this properly for you. And perhaps we should be thinking about whether we should be doing fasting Fibroscans on everybody, but that's something, that's an area of research. So how does it work in the context of hepatitis B? As I said to you, cutoffs are very, very different, and we really need more data to validate elastography in the context of hepatitis B, and particularly in the context of hepatitis B and HIV co-infection. The other thing that elastography or Fibroscan is very useful for is predicting portal hypertension and risk of esophageal varices. And there's some very nice data, again, this is old now, to suggest that the higher your reading, the more likely you are to have raised HVPGs. And in fact, there is a nice relationship, almost a straight line relationship between HVPGs and your Fibroscan or your liver stiffness. So having looked at all of this, we go back back to the question that we asked many slides ago, is that we know that histology predicts survival, predicts risk of hepatocellular carcinoma, and predicts risk of complications from end-stage liver disease. Will the non-invasive tests do exactly that? Because that is the question that your patients don't ask you. If you do a Fibroscan on me, will that predict my risk of morbidity and mortality? And clearly there is now data to suggest that if you use Fibroscan cutoffs and transient elastography for cirrhosis, you can predict outcomes in terms of mortality and morbidity from end-stage liver disease. And so that really answers that question, that elastography is useful in terms of predicting clinical outcomes. What about trying to put tests together so that you can increase sensitivities and specificities? This is the sequential testing algorithm where you combine two different non-invasive tests in terms of concordance or disconcordance. If there's concordance between tests, then you confirm fibrosis or significant fibrosis. If there is disconcordance, then perhaps those are the patients that you might want to think about a liver biopsy. And there's a number of different safe algorithms that combine a number of different tests that one can use, and you can even combine, say, a blood test with a Fibroscan. And what we do in clinical practice is combine very simple tests like APRI, where routine laboratory parameters are used to calculate your APRI scores, and combine that with Fibroscan readings. And if there's concordance, then one believes that that's the amount of fibrosis that particular patient has. So in terms of clinical use, certainly very useful in the diagnosis of cirrhosis in patients with viral hepatitis. And so you can actually say to people, you've got advanced liver fibrosis and you need to go on for hepatocellular carcinoma monitoring and for complications, portal hypertension. It's very useful in treatment decisions in hepatitis C, may be useful for monitoring of hepatitis C patients not on anti-hepatitis C therapy, so looking at progression of liver fibrosis. It can be used for decision-making in hepatitis B. We need more data, and certainly there's increasing data that it can be used to predict fibrosis in NASH, or a non-alcoholic steatohepatosis. This is another combined algorithm where you combine Fibroscan together with one of the serum indices to predict the level of fibrosis that one has. Okay, so that's what we have available to us at the moment. So we have Fibroscans, we have blood series, and we have liver biopsy. What's coming on? What else can we do to monitor liver disease or to assess liver disease? This is MR elastography. I was in India a couple of years ago at an institute in Delhi where they'd asked me to speak about Fibroscans, and so I arrived trying to do a big talk on our experience of Fibroscan use in the UK, and the first thing they said to me is, well, we actually use MR elastography, and we've got 2 MRI scans that do elastography, and so I had to stop straight away. MR elastography, in fact, is something that's being increasingly used in many parts of the world where Fibroscans are not available. The advantage of the MR elastography is actually measures stiffness in the whole liver rather than just a portion of liver that the Fibroscan uses. And so, if you can get the equipment together to do MR elastography, I think it's a very, very useful tool and probably is a better way of assessing liver damage than the Fibroscanner. There is this thing called the acoustic radiation force impulse, which is very similar to what we do in the Fibroscan, but you can get an ultrasound scan and a liver stiffness reading with the same piece of equipment. This is the Siemens bit of equipment, and again, this has been validated too, and this is, some places are starting to use this as a combined tool, so an ultrasound scan together with liver stiffness in one sitting. What's really exciting in terms of technology for the Fibroscanner is the ability to now assess fat in the liver using this particular algorithm, which is a CAP calculation within the Fibroscanner, which tells you how much fat there is in that liver. And so for patients with NAFLD and NASH, this may be a tool that we'll be able to use in the future. So where is the future? And I have to say, having done all of this, I'm moving back to liver biopsies, because I think liver biopsies are particularly helpful in co-infected patients, and the transjugular liver biopsy. This is what we're beginning to do now at the Royal Free, where we need liver biopsies. We do transjugular liver biopsies, which are A, more acceptable for patients, B, have fewer complications, and C, can allow you to take multiple cores of liver tissue, especially when you need liver tissue for microbiology, cultures, etc., etc., etc. So I'm going to stop there. Thank you.
Okay, thank you.